Good evening. On behalf of the Student Academies of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar, Insurance Basics for Audiologists. My name is Andrew Abernathy, and I am pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. If you have any technical challenges during the session, please use the chat feature to make me aware, and I'll be glad to assist you. Please type your questions into the question queue, and they will be addressed by presenters at the end of the presentation. Today's presentation is being recorded and will be available for online viewing next week. At this time, it is my pleasure to introduce the course moderator for the session, Anne-Marie Egan, SATA Board Communications Chair and third-year audiology student at the University of North Carolina.
Thank you, Andrew. On behalf of the SATA board, I'm excited for the opportunity to welcome audiology students from programs across the country to this session on insurance basics for audiologists. It's also my distinct pleasure to introduce today's course leader, Dr. Deb Abel. Dr. Abel, AUD, is the Manager of Coding and Contracting Services for Audiology after serving as staff at the American Academy of Audiology and is the President of the Academy of Doctors of Audiology. She has also had her own private practice in Alliance, Ohio. Dr. Abel is the editor of the Essential Guide to Coding in Audiology, Coding, Billing, and Practice Management, the author of a chapter in the Essential Guide to Coding in Otolaryngology, Coding, Billing, and Practice Management, the 3 editions of Strategic Practice Management, A Patient-Centered Approach, Business and Procedural Considerations, and has authored articles in various audiology publications. Until recently, she was an adjunct assistant professor at A.T. Still University. Welcome, Dr. Abel.
Thanks, Anne-Marie, and Andrew, thank you as well for being with us tonight. And for all of you out there, thank you for joining us. So this is pretty basic in terms of insurance knowledge, and because this is geared for students and early professionals, but I understand some of my colleagues may be attending too, and we're happy to have you, and I hope it's helpful for you as well. So we will go ahead and get started with trying to move the slides. There we go. So I want to just let you know what you're in for the next little while that we have together. When we talk about insurance, we certainly have to talk about sort of the one that everyone looks to, and that's Medicare Part B. And I know Dr. Cavett is going to discuss, if she hasn't already, this section. So I will forego that and leave it up to her wonderful expertise. I'll highlight a little bit, and she may as well, Medicare Advantage plans, which are considered Part C. And then that's where the third-party administrators come into play, is because of the Medicare Advantage plans. So we'll talk a little bit about those too. We'll talk mostly about commercial insurance and types. What types are there? What are the definitions, so that we're all speaking the same language. We'll talk about credentialing and contracting and things to think about as you go about doing that in your own practice. Workers' compensation is also part of an insurance benefit that you may want to offer in your practice, or if you're in a facility, or if as a student, you'll see these other kinds of payers as you go about seeing patients. Also, vocational rehabilitation is everywhere in every state and is administered differently. And then finally, one of the largest employers of audiologists and one of the largest users of hearing aid services is the VA. And there's several aspects of that, and we'll lightly touch on that, with the VA being mostly active duty. And then there's also non-VA providers that includes audiologists, those that are doing compensation and pension exams, for example. So let's go ahead and start with Part C. So what this is everybody gets Part A, that's the hospitalization side. Then patients can, or enrollees can choose Part B if they want, and they're going to pay roughly, at least in 2020, depending on how much income you made, you may pay around $144.60 a month for a premium. It goes up if you had a higher income rate. So that's why it's income dependent. And then there's a $198 deductible, which I have a $3,000 deductible on my current health care, which I chose to do. But 198 is looking pretty good. So this is something patients pay extra. They have to be enrolled in Medicare Part A and B in order to get a Part C plan. They may be paying anywhere from $0 up to $300 a month to have that Part C plan. So as a result, if you're paying $300 on top of your other premium of $144.60 or whatever it is, you're going to expect to have some perks with that and some benefits. And that's where the third-party administrators come in. So offering a hearing aid benefit doesn't cost an insurance company a lot of money to do that, but it looks to the beneficiary like it's a very big deal, and in some cases it is. But not so much on the provider side, as we all painfully know. So there may be a copay. That's a certain set amount, and I'm going to go over that in the definitions. But there may be a copay that is required when somebody enables one of their hearing aid benefits. There may be a quote-unquote discount plan where you'll see this advertised usually around November. You'll start seeing all the ads in the paper for people to switch because they have that chance once a year to switch whatever their benefit is. And then they start looking at apples to apples. And if I get a hearing aid here, can I still get this plan with a hearing aid benefit here? And which is the better benefit? Do I have to pay $7.99 per device out of pocket, or do I pay $6.99 out of pocket? So those are the kinds of things people start looking at in around November, maybe even October. But just so you know, you'll see all those advertisements in your local newspaper. So you can kind of be ready, because sometimes patients will ask you, if I decide to get this plan, you know, what's going to be my best bang for my buck when I decide to get hearing aids. So again, Medicare Part C is an Advantage plan, and they may include things that traditional Medicare Part B does not. There are some that include routine annual testing. Medicare Part B does not include that. There again, Medicare Part B does not cover anything related to hearing aids. They don't cover the device. They don't cover any services that are related to it, but a Part C plan may. The interesting thing about Part C is that they do require a fraud and abuse training every year. You have to go online and read some scenarios, fill out some questions, and then you usually get a certificate when you've completed that. And the other thing that's interesting about Part C plans is that they are supposed to audit one of your patient charts every year. So don't be alarmed if you get a letter from them saying they want a chart of, you know, Mary Brown was seen on blank date, and you have to submit that. Usually that's, if you do your documentation correctly, usually that's not a problem at all. And if there is a problem, they'll come back and ask for more charts and audit those as well. So those plans often have relationships with what's called a third-party administrator. It's not through them directly. So let's take an example. You've got, you know, maybe an Aetna plan or a Blue Cross Blue Shield plan that the patient has as their Medicare Part C premium. But those plans have contracted with any of these companies you see here on this slide, be it True Hearing, Amplifone, Nations Hearing, United Hearing Healthcare, which used to be known as Epic, Hearing Health, American Hearing Benefits, Hear USA, Hearing Care Solutions. So they may have already had an arrangement so that when you submit your bill, maybe it's to Aetna or Cigna or Blue Cross Blue Shield, it gets taken over sometimes, not always, and is sent over to True Hearing. It depends on the structure. Some companies have a portal. You just order the device through the portal. The patient pays that company, say True Hearing, and then you get to bill the patient within a certain limit for services. So, and they'll tell you what those are and how much they'll pay. So I'm sure Dr. Cavett will go through with you medical necessity, which is defined in the Social Security Act. Audiology and what an audiologist is also defined in the Social Security Act. And the most important part about all of that is that it is is what you see in bold. It's for services that are reasonable and necessary for the diagnosis or treatment of illness or injury, or to improve the functioning of a malformed body member. Now, Medicare is not the only one that is critical about having medical necessity met. Every single payer is. It just seems to be a little bit more known as far as Medicare goes. But for all of those things, it should indicate that you need it for diagnosing or treating whatever the patient has. So that's the very important part of all of this. So it also means that it's a change in hearing balance and or tinnitus, and that has to be included in your documentation. If it's not, and there is an audit, you don't have a leg to stand on. So as I alluded to in the coding session, if you were with me at that point for that webinar, it has to be, it could even be the first line of your documentation. Patient presents with tinnitus, they have hearing loss, they're dizzy, whatever it is, and then that usually meets medical necessity. So I want to preface all of this information with saying that insurance can be beneficial to your practice, and it can also be a detriment to your practice. And you have to be wise as to what plans you choose to take, who you contract with, what that contract says. And there's very, very many layers to all of this. I will tell you that there are audiologists who take no insurance at all, and they're doing just fine. So you have to look at the demographics in your area and see, and we'll talk a little bit more about that when you decide if you are going to take any contracts. If you're in an area that is heavily based on maybe industry, that industry area probably has a lot of contracts that may cover hearing aids, and you need to look at that when you make your decision. So only you can make that decision for you and for your business. So if you're starting to think, I see this patient come in and that patient come in and they all seem to have the same insurance and I don't take that insurance right now, it may behoove you to reach out to that insurance company and see what's involved in getting a contract. But it's generally contracting and credentialing can kind of go hand in hand. Some people think credentialing should happen first. Some people think contracting should happen first. I take the stance of credentialing can happen first because all the contracted companies are going to go to, you see a link on this slide for CAQH. That's sort of like a repository of all your information. You fill out forms one time, the insurance companies can go into that repository, snag the information that they need, and you don't have to keep doing this for every single payer. Before CAQH was available, anytime you wanted to have a contract with an insurance company, you had to go through, pages and pages of information that always include a copy of your state license, what your MPI is, the MPI of your business, your tax ID number of your practice as well. So these are all things you don't have to do so much in repetition like that. It's all just housed at the CAQH. You have to update that information. I think it's quarterly now to make sure that it's pretty timely. For Medicare, we talked earlier about Medicare Part B. When you decide to enroll, they want to see a copy of not only your state license, and also the other information that you see there, your MPI, your tax ID number. They want a copy of your terminal degree too. So for those students, of course, would be your AUD. It may take 60 to 120 days to be credentialed, so it takes a while. So once you get your license, you can go to CAQH and start your credentialing, depending on your situation for your employer. They may be able to help you with that. And they need that kind of information as well. And then they know what contracts, hopefully, your employer knows what kind of contracts you have, who they're with, and need to get you quote unquote credentialed with them and contracted with them. So you want to ask some questions when you are contracted, if you're doing this sort of on your own. And there are companies that can help you with that too, so that you're not doing this all by yourself. But you want to see at what point will they start, when you can start providing services, what's the first date of service, so that you know that going forward. So you always want the contract and the fee schedule. So again, you're going to need your tax ID number, whether it's your tax ID number or your EIN is employer identification number. You'll need the NPIs for you and any of the providers in your practice. If you're a sole proprietor, if you have a large practice, you need all that information for the practice as well as for all the providers. There are some insurance plans that will only credential and contract with audiologists. So if you have hearing instrument specialists on staff, you certainly want to ask that question if they can be credentialed as well and contracted, because like I said, some are not. And that means that the audiologist would then need to see that patient, and only the audiologist. Some payers won't allow students to be involved with their subscribers, so you certainly want to ask that question as well. Can a student be involved with the testing and that type of thing? And usually they'll say yes, but certainly you want to make sure what the answer to that is. Again, you need a copy of your state license. You also need liability coverage. That's your malpractice insurance. And if you are a practice owner, you need it for yourself as the provider, and you need it for the practice as well. Most insurance contracts, when you read through the contract, it stipulates this number you see there, the 1 million and then 3 million. That's very typical. And for all the professional associations, and there's the link to get that through ADA, through Trust RMS, that's the kind of plan that they have anyway. You don't usually have to request anything different or more. It's called 1 million, 3 million, and it's pretty well known in healthcare, at least for audiologists, that's what that entails. Then, so that's Medicare mostly, and also now we're going to start talking about some more nitty gritty as far as the commercial insurances. I'm sure many of you, especially those of you who've had a life in California, that's where the health maintenance organizations began many years ago, and they've kind of moved across the East, and I'm not sure how successful they've been across the East and Midwest, but HMOs are capitated. That means everybody that is in that plan pays per member per month, and that's a certain pool of money, and all the visits for that patient come out of that pool of money. So you've probably heard of Kaiser Permanente. They've been around a long time. That's a really good example of what an HMO is. So if you need a service from another provider within Kaiser Permanente, that's covered. If you need a service that is not provided by that Kaiser Permanente area of where you are located, you have to go outside of that. You have to get an authorization to do that, and it can be very intensive. Then you also need, when you have an HMO, there's a gatekeeper. It could be a primary care physician, it could be internal medicine. Somebody like that is ordering the services that he or she can and can't provide. So if it's somebody that's within, a lot of times these are like big multi-specialty clinics. So maybe you go see your PCP within Kaiser, you need some kind of an ophthalmology exam. They'll refer you to a Kaiser ophthalmologist, and that way it kind of stays in the family. You generally need authorizations for hearing aids, and not all HMO practices do that. So they may actually be sending them to you if you're outside of the Kaiser family. And generally there's an order and a process in which to get that done. So that's an HMO. Another type of organizational insurance company is called a PPO, or preferred provider organization. This is what a lot of people have. You have the ability to choose your healthcare provider in a PPO. The provider has agreed, the provider you choose has agreed, as has the payer, to agree to some kind of a discount structure. Basically, it's a negotiated rate. Maybe generally, let's just say you charge $100 for 92557. They're not going to pay you $100. You've negotiated a rate that, let's just say, is 75, and that's all you're going to get. So that's a guarantee you'll have those patients, but you have to give something up in order to do that with many of these plans. They still are allowing fee for service, and that means you get paid for all the procedures that you do and for each procedure that you do. Then there's sort of a hybrid. The point of service, or POS, is sort of a combination of the previous two, the HMO and the PPO. So it's kind of a combination. So in-network means you stay within that plan. You have a gatekeeper, but you can go outside of the plan. It's going to cost you more, but you have that option to do that if it's somebody you prefer to see. Maybe there's a specialist of an area of concern that maybe you're not so sure. You want to stay within network. You want to see this world-renowned physician. You'd pay extra in order to do that. Then in the last 10 years or so, as a result of some of the healthcare legislation, there are something called ACOs, and these are not as common at this point in time. They're called accountable care organizations, and it's when a group of like-minded healthcare providers, and they can be the same kind of provider. They can be multi-specialty clinic types of things. They can include audiologists, but they kind of group together to share in some common things that'll be beneficial to each of the providers. And then they also share in the risk, because if they wind up seeing patients who are chronically ill patients cost more to see than a healthy patient. So they're going to lose money if they see a lot of chronically ill patients. I don't mean to sound cold about that, but healthcare is a business, as they say. So I think it's helpful when we speak the language. I'm going to go over some definitions, because when you call to verify certain benefits, whether it's for hearing aids or other services, tinnitus, vestibular, rehab, whatever, you want to be speaking the same language. I saw this picture of this woman with the microphone, and she looks actually happy. And I will tell you, when you make an insurance call, no one looks like that. So it's not always the most fun thing to do, especially if you've been on hold for 20 minutes. I think I saw this on Facebook. Your insurance should cover this, but it doesn't. And that's sort of how you're going to feel some days, unfortunately. So I'm going to close one of my windows here because I can't see all my slides. There we go. Okay, thank you. So let's go through some of these just so we're speaking the same language. And for those of you who are providers already, some of this will seem very simple, and maybe it's kind of reaffirming. But for the students and the new professionals, I think it's important to talk about when you're dealing with insurance companies. And I will tell you, it seems like more and more that's going to be very common. Hearing aids are often a benefit, and I use that word, hearing aid benefit. I think that's can be an oxymoron, so that you'll be aware of some things to think about, some pitfalls and pratfalls, if you will. So in-network means the provider, that would be you, is contracted with the payer, and you agree to accept and participate with whatever those in-network fees are. You get your contract, you get a fee schedule, you think it's going to be fine, you go ahead and sign it, now you're in-network. So generally, and this is always in the contract, and I want to highlight this to you, for covered services they're going to cover, they generally do not allow you to balance bill for covered services. So if you've agreed to take $50 for 92557 and your usual and customary charge is $100, you cannot bill the patient that difference of $50. You have to basically eat it, write it off. It never was really real if you decided to accept the $50 as a contracted rate. But you can, non-covered services are generally allowed to be balance billed. So for example, there are several large major insurance companies like Cigna and Aetna who have policies on their website. So if you decide to contract with somebody, look at what their policies are on their websites. And for example, if you decide to do tinnitus treatment, one of them has a policy, pretty long policy, about how it's considered experimental in their standards and they won't cover anything. Well, since they won't cover it, it's a non-covered service and you can bill the patient for that privately. So because it's not covered isn't necessarily a bad thing. So I just want you to be aware, and that's often listed right there in definite language, very specific language in the contract. Out of network is kind of the opposite. You've agreed not to contract with a payer. You can bill the patient what your usual and customary fees are. The patient's going to pay a higher amount, but if they want to come and see you, they will. Usually how things work with in-network is maybe the provider gets 70% or 80% and the patient pays the difference. With out of network, it's maybe like you get 60% and the patient has to pay 40%. So it's a little higher it's lower for you if you're out of network possibly, and maybe not always, but it's more expensive absolutely for the patient. A deductible is something that you have to meet every year in order for your insurance to kick in. So if you, like I told you, I have a $3,000 deductible with my current healthcare plan. That means I have to spend $3,000, the first $3,000 of any physician or other qualifying healthcare visits in order for my plan to kick in. So once I cover that $3,000, then anything else should be minimally out of pocket for me. But it's a bite to get there. In that varies. Sometimes it can be $500 a year. Generally, you as the patient can determine how much deductible you want to pay. It can be up to $7,000. Some of our patients have a $7,000 per year deductible. So that means if they buy hearing aids, it should go towards their deductible if they haven't met that already. So you have to collect deductibles from the patient. And you have to do that with any healthcare provider that they go and see. And if you're one of those, then you have to collect whatever that deductible rate is. So it may get applied to their amount, in which case they owe you for that. And sometimes you can check those things on the website of whoever the payer is. A copay is a specified predetermined amount. It's usually listed on the front of their insurance card. It can be anywhere from $10 to maybe $50, and that can also be collected. The insurance company may not cover a copay, in which case you'd have to refund it, but it's certainly worth a try, especially if it's a new plan and you're not sure. Over time and with some experience, you'll see that if you know this payer isn't going to cover it because you can't charge an office visit, which is generally how that all works. If you can charge an office visit, generally a copay will apply. But I'm not even going to talk about office visits because we could talk about that for 2 hours. So just Medicare doesn't recognize us for that, and consequently many payers don't either. Co-insurance is something that Medicare Part B does use, and it's a percentage of what the patient owes. It's not a specific fixed amount like $25 for the visit. It may be like $14.95 or something kind of odd like that, but it's a actual percentage of what they owe. The allowed charge is the amount the payer will allow for payment. So if there's a benefit and it's, let's just say for hearing aids, and it's $5,000, don't always believe that it really is $5,000. Oftentimes it's $2,500. That's all they're going to pay. And if you're contracted to accept that, you don't want to take a bath and get hosed by dispensing premium hearing aids when you're going to get $2,500 in payment. So you have to kind of be very careful about that. And that's when itemization comes in handy, because oftentimes if you don't itemize, the payer doesn't know what you're billing for. So if you itemize for your professional services, the chances of optimizing your reimbursement goes up, and you certainly want to have those codes on your fee schedule. Fee for service, again, is you get paid for everything that you do by procedure or device or whatever you have there. Okay, let me shift the slide again. Thank you. Okay. All right. So balance billing is a very commonly used insurance definition. And when I was a lot younger, I used to think it was the difference between what the patient owed and what was billed, but it's not. It's the difference between what the insurance company allowed and what was billed and paid for by the patient. So that's the part, if you're contracted, that you may wind up writing off. Billed charges is what the provider billed the payer for. So if you normally charge $100 for 92557, that's your billed charge. The allowed may be $80, for example, and then you write off the 20 if that's what your contract is. For some things, especially things considered experimental, like I said, tinnitus treatment, you want to get a pre-authorization or a predetermination, because you want to have in writing, and that doesn't always mean everything, but it's a leg up. You want to have that in writing as to what that insurance company is going to pay for what you want to do, and you want to give that to them in some detail. Medicaid in most states do require prior authorizations for hearing aids. So it takes a little while to get that approved, but it oftentimes takes even more time to get paid. So, and again, if you're not sure, like I'll give you another example, a BiCross hearing aid, especially since the codes changed about 2 years ago. If you're not sure, and there's one payer in particular, doesn't seem to like BiCrosses, doesn't seem to pay for them. So you would definitely want to send in some kind of a predetermination to make sure that you and the patient both understand what's going to be covered and what's not. So some of that, again, may wind up being an out-of-pocket expense for that patient. No hearing aid should ever leave an office without anyone knowing who's paying for it. So sometimes this takes some time, unfortunately. And just because two patients work in the same place and you think they have the same insurance, they may not. There's all kinds of cafeteria plans. So patient A may have something different than patient B. So a lot of practices have the luxury of having somebody who is dedicated to verifying benefits. And I know at Audigy we have a verification form. They're the most common, and you can create one yourself too. The questions you want to ask: can the patient share in the cost of an upgrade? That's probably the most critical question. Can we use a waiver? And I'll talk about that in a little bit here too. Just because you have a verification doesn't mean, and they'll say this to you on the phone as you wait for 20 minutes on hold, that it's just because they tell you something is covered, it's not a guarantee of payment. So there's something called a reference number. You want to get that during the call or at the end of the call. Do not hang up without it, because it is, they record these phone calls, and if you have a reference number, they can go back and listen to that call. And in some cases, it's the best ammunition for what to fight and you have an appeal for what they didn't pay when they did say they would pay. I can give you a quick instance. I used to do some of the verification calls myself when I had my own practice, and I would do it in front of the patient so they could hear as well. And so somebody didn't give the right information. The patient heard it, I heard it, and we just kind of pushed a little bit, and they went back and listened to the call, and sure enough, because of how she said it and what she said, we did get that taken care of. A write-off is just one of those things when you're dealing with insurance companies, because they don't pay everything to the penny. You write some of that off, and it can't be filed. If you're contracted for that, you can't file that to the patient. You just write it off. It kind of goes out in nowhere. Some people always ask, can I use that for a tax deduction because it's a loss? But it is a loss, but it's also the cost of doing business. And no, you can't use it when you're doing your taxes of your practice. So, you also have to look at things like patients not being able to pay their bills. But again, no hearing aid should leave an office without it being paid for or knowing who's paying for it. So anyway, you don't want to have to send a patient to collections, because generally you get about half of what they can collect. So again, you're in a situation of having to write that off. Coordination of benefits. There's so many people that have 1, 2, and even 3 insurance plans, believe it or not. So you always want to know who's the primary, who's the secondary. If there's a spouse, they may have a different plan, and then they have maybe their spouse is primary, and then the other spouse is secondary. So you kind of have to ask those questions and get those right health cards too. Okay. Let me get the slide to move. Sorry. There we go. So once you submit a claim to an insurance company, hopefully you get a check. Sometimes it'll be what's called an ETF, an electronic transfer funds, or EFT, sorry, electronic fund transfer. That's how Medicare will pay you. They don't send checks. They just drop this right into your checking account. And it just appears one day, and it's a one-way valve. And some insurance companies will do that too. And by one-way valve, I mean they can deposit things in that account, but they cannot withdraw anything from that account. So once it goes through the process, so if you're filing electronically, the claim gets sent off to your clearinghouse. Your clearinghouse submits it to the insurance company. The insurance company deals with it, whether it's electronic or hard copy, and they determine what they're going to pay. And then what they do is they send something to you, and they send something to the patient called an EOB, or an explanation of benefits. And it's a detailed summary of everything that was covered for that data service. It includes the services rendered, the data service, if there's a copay, what they pay to you, hopefully, what the patient's responsibility is. And it's not standardized. The CMS 1500 form is a standardized form, and this is what it looks like. So if you submit this hard copy, this is what the claim form looks like. It's got all the information for dates of service, the patient's insurance company, your NPI, your address, your diagnosis, what tests you did, the date of service, that's all here. this is what you're going to get back. And it doesn't look the same from one insurance company to another. And that's what makes this kind of a little bit more difficult. So this one's just a sample. And you can see, just looking at it kind of quickly, you can see what CPT code what they used, how many of them they did, what their billed amounts were, what their deductible was that got applied, and if they had a copay or a co-insurance, and then it tells you how much was actually paid to the provider. This is just something I got from Aetna, and it has a little bit more information, and it's kind of nice that it has things laid out. And again, some are very easy to read and some are very difficult, but here's kind of the guide to the one you just saw previously. But let me go back to this just for a second. So you want to review this when you get it, because, or have whoever you have in your office needs to review these to make sure you were paid appropriately by your contract. Don't assume insurance companies are going to do this correctly, because they make mistakes. So in your practice management office system, you can put in there what they should have paid so that you can see when they do pay whether or not it was paid appropriately and correctly. So several years ago, ADA, ASHA, and AAA all wrote a document, and here's where it is listed on the ADA website. And these are things to consider when you're looking at having third-party payer contracts, and that's any third-party payer, commercial, third-party administrators, whoever, when you're considering taking insurance. So you have to be in compliance with all the state and federal laws, and here's just a list of them that may apply in your state. I'm going to tell you, you need to get legal counsel involved. I know that's expensive, but it can keep you from, a bigger expense later on down the road. So you need to, when you first get your contract, go through it, redline it, and then you can submit it back to them. They're boilerplate. So you're not expected as an audiologist to provide services 24/7, but if you sign the contract and you didn't eliminate that sentence, you're bound to do that. So if a patient decides for some reason to call you at 3 o'clock in the morning, you're supposed to be on call to take care of that. So you want to look for that. Some contracts say that you have to see the patient within so many hours, maybe even 48. You may not be able to do that, so you can redline that as well. Some contracts have, that you have to provide your Drug Enforcement Administration number. You don't have that, so another thing to redline. So look through it and then submit it to your legal counsel. And if you don't know, how do I find somebody like that, which is a very common question, I'm going to tell you to ask your own primary care doc who they use. Call your local hospital to see who their attorney is. You can certainly call your county bar associations or your county medical societies, and they should be able to give you some names, and then interview them. But don't just pick your friend who is a divorce attorney, because they don't know necessarily about the important things about healthcare. Not that they're not a good attorney, it's just this is a very specific type of law, and very specific situations. You want to make sure you have somebody that knows what they're doing. When you look for the fee schedule, sometimes they're in extremely small print embedded in the contract, and it's almost like looking for a needle in a haystack, as they say. It may be an appendix or an addendum at the end, in which case you can just cut to the chase and go right to it. The hearing aid codes may not be listed there, just maybe the diagnostic ones, in which case, before you sign the contract, you want to have those in your hand before you decide. So in a way, it's kind of like roulette. If you don't have the fee schedule in your hand, especially for hearing aids, you have no idea what they're going to pay. And you certainly don't want to dispense a premium hearing aid if all they're going to pay for, and this is very common, a basic or standard level 1 kind of device, unless you can bill for the difference, which is called an upgrade. So the other thing that's notorious with one large payer is they'll only pay a percentage of what you submitted the bill for. So let's say you submit the bill for two mid-level hearing aids at, X thousands of dollars. They're going to decide, because that's what you submitted as a bill charge, they're only going to pay 50% of that, maybe 60% of that. So you need to know that ahead of time, and don't listen to them when they give you advice on the phone about how to readjust that. When you decide what your fees are, you have to make sure that with whatever contracts you have, that you can still make what you need to make in terms of your hourly rate and all of your expenses and things like that, with still being very realistic. You may see verification for diagnostic procedures on their websites. They probably don't have the hearing aids. And you certainly, again, need to call before the patient leaves with that. So as you're deciding, who do I choose to contract with, you can look at the largest employers in your town, see what plans they have, see if they're accepting new providers, and then ask for a contract, and then you can review it. If patients come in and you see this patients come in with the same contract, certainly you can contact them too. You also want to be on the same plans as some of your referring physicians. That's a really good carrot to get them to refer to you, is because that you're on the same plan as they are. But the bottom line is whoever has the most sustainable reimbursement and reimbursement that you can accept and still provide a good service and make money to keep your doors open is certainly the contract that you want to go with. You may be in situations where they tell you, oh, sorry, our panel's closed. We're not accepting any new providers, but keep trying. At some point, maybe people will drop out. Maybe there's a reason why you don't want to be on there. So again, I would keep trying. Don't sign anything without legal counsel taking a look, and you want to look at your contracts annually, and you can do that on your own. You don't necessarily need an attorney, but you can certainly use one if you need one. And always keep a copy of your contracts. Once you sign it, and they usually send one back to you signed, but keep those in a safe place, because it's amazing to me how many practices have no idea where their contracts are. They're old, they may be 10 years old, maybe you've moved, things happen, but you always want to make sure you have a copy of your contract. Don't sign a contract out of fear. Just because you think somebody down the street may take it doesn't mean it's a good contract for you. There's bad contracts out there. And then I know this will sound like almost like a prenup with a wedding. If it's not a good arrangement, you can terminate it, but you want to know what that termination process is before you sign the contract. If you are enrolling with one payer, maybe there's other payers you wind up being on automatically, and you want to ask that question, because those are plans that may not be beneficial to you. You want to know also in the contract, it usually states, when do you have to file the claim? Is it 30 days? And if you file in day 35, you may get that claim denied, and then you cannot recoup that from the patient either. So you want to know what the timely requirements of the plan are, and you also want to know what the timely requirements of your state are, and that's usually determined by your state insurance commission or your state tax department, so that maybe they'll say a claim has to be submitted within 45 days, and that's considered timely filing. So you just want to keep that in mind. So when you talk about balance billing, it's really, as I said earlier, it's a difference. The insurance company thinks it's a difference between the allowed and what is owed. But for those patients who have a basic hearing aid benefit and they want to get an upgrade, you want to ask, can the patient share in the cost of an upgrade? If they don't understand what that means, you can say, like with a vision benefit, you get a basic glasses, you get lenses, but maybe I want tinted lenses. Maybe I want progressive lenses. Maybe I want designer frames. I'm going to pay out of pocket for all of those things. This is the same thing. So can the patient share in the cost of an upgrade? Then you want to ask if they say yes, and most of the time they do. Then you need to ask, do you have a waiver that we can give? That would mean the patient understands that they are responsible for whatever that difference is. So again, at Audigy, we have a sample waiver, and many other places do, and a lot of insurance companies have that as well. So you still have to collect the co-pays, the co-insurance, if that's how their plan is working, and certainly you have to collect the deductible. So you want to ask the payer, do you have your own waiver? Can we create one? These are the things that need to be in the waiver: the patient's name, the date of service, what their financial responsibility is going to be if they choose to upgrade for a hearing aid, and that they have to understand this is beyond their benefit. And when they get their EOB and it says patient responsibility and it says 0, that's for covered services. And that's where it gets ugly, because patients often say, hey, you owe me $3,000 for my upgrade fee. No, your upgrade's a non-covered service. They don't have responsibility for covered services. So this helps eliminate some heartburn when you include that on your waiver. You want to have them sign it at the date of service. It's a great time to educate the patient on covered services and non-covered services. Especially people my age and older seem to think insurance pays for everything, and we all know that's not true. So it's a good time to educate the patient as to what their responsibility is going to be. And you want to include the codes of what you're going to do, give the patient a copy. And then the ABN is the Advanced Beneficiary Notice, is used for Medicare. This is something different. Then for those companies that do allow for an upgrade in technology, there is a code S1001, and by definition, it's deluxe item, patient notified. So you could bill the upgrade with S1001, and oftentimes they'll then, if they recognize that, and you want to ask them that, then they'll often put that right into the patient responsibility column on their EOB, and it makes life so much easier. So once you get contracted, you want to look at that contract and the fee schedule. You can ask them for a fee schedule and see if it's updated. As time goes on, it's amazing. People are sitting on contracts that are 10 years old and have had no increases. Your fees have gone up, your rent's gone up, the cost of hearing aids have gone up. So these folks also should be paying more as well. So you want to be clear about if you're in or out of network. Again, you want to be credentialed. You want to know what the denial process is. And then if you choose to, this is just not working out, they're paying later than they said, I'm tired of chasing these claims, that kind of thing, you decide to terminate it. You want to send them a certified letter, and you want to give them whatever time in the contract, whatever it stipulates. It may say you can terminate in 90 days. If you don't do that, because they put your name on the website, they put it in provider manuals. If you don't give them the appropriate amount of time to terminate the contract, there's a potential to be accused of patient abandonment. And I've never seen anything about patient abandonment when it comes to audiologists, only physicians. But let's assume that it still stands. So you don't want to be, accused of patient abandonment. It's pretty devastating. You can't set your fees unless you know what your hourly rate is. And I think Dr. Spohr is going to talk to you about that over the next few weeks. That's where itemization comes in really handy, because you're going to get paid. When it comes to insurance, you'll get paid not only for the device, but also for your professional services. There are some plans that are awful. I can remember seeing a contract that all you were going to get was $400 for a hearing aid. That included your services. Why anybody would sign a contract when the device and your services and all you're going to get is $400? You can't keep your doors open for that. So you want to make sure that you're not signing one of those kinds of contracts. Again, review them periodically. Look on their on the payer's website or newsletter, because they'll probably throw that in your face if they make a change and they'll say, well, we put it on our website. Well, who looks at that? So maybe whoever you have in your office, maybe one day a month, they can just go to these payer websites and see if there's been any changes with any audiology policies or fee schedules or anything else like that. So you want to review their policies, and each payer is different. Some don't even have policies, but I thought it might be helpful for you to look at this example that's on a Blue Cross Blue Shield of Michigan website. And there's the link if you want to do that. And again, don't assume the insurance company paid you correctly or properly. They do make errors. Medicare does too, especially when it's the beginning of the year and things have changed. So you don't want to write off more than you already have to. So always look to what is your contracted rate, and is it reflected appropriately in the EOB? So you don't want to undercut yourself in setting your fees, and that's why it's so important to know what your hourly rate is. When you go to contract, you want to ask, how many patients can I expect to see? You don't want to have to give anything away. Some do require that you submit an invoice because that's how they pay you. They'll pay you like 105% or 125% over the cost of the invoice. If that's the case, you don't have a whole lot of choice but to submit it. But if they're paying X amount of dollars for the device and X amount of dollars for your other services, there's no reason to send them an invoice. And if you do have to send an invoice in situations like that, and I'll give you an example. There's one insurance company who I'm not sure what the motivation is, but they will ask for the invoice, they'll ask for the purchase agreement, they will ask for chart notes because they want to make sure those hearing aids were dispensed on that date of service, and they're looking to check the serial numbers to make sure the serial numbers match up to the information in the chart. They've been doing that for probably a year and a half, 2 years now. So that's critical. And I'm going to have to cough here for a second. So let me flip up my mic. So sorry. Stuff gets me so excited. Anyhow, so you just want to make sure that you know exactly what you have and what you're doing. So if you decide you want to provide a niche service, sort of like tinnitus treatment or central auditory processing, make sure that you could certainly get a predetermination, but it's probably likely that they'll consider that experimental and not pay it. But then that means the patient can pay privately if you so choose to do that. Again, you want to make sure you know when you have to file the claim. Some third-party administrators want to make sure the patients had their 30-day trial period. And again, going back to that one company who wants to be sure when they ask for all that information. One of the reasons, and I'm getting ahead of myself a little bit here, is if you bill, and this is so commonly done and it's so wrong and it's actually illegal, that oftentimes providers think they're doing the patient a service by saying to them, well, let's go ahead and bill your insurance company, see what they're going to pay, then you'll know what's covered and what you owe. That is a false claim. You're billing for a service that was not rendered. You cannot use a demo or a loaner. It's got to be their very own device. So the data dispensing, it's got to be their own devices with their own serial numbers. And that's why I think that one third-party payer is looking at all that paperwork. Okay, so let's move on. And again, you can't bill for a service that was not rendered. So you always want to verify. So there are some of the third-party administrators that require free hearing evaluations to dispense and purchase hearing aids on the patient's side. If you're enrolled in Medicare, you cannot give a service away for free if you're billing Medicare for that same service. So Medicare does Part B, that is, does not pay anything related to hearing aids. So you could call it a hearing aid evaluation, you could call it a communication needs assessment, in order to kind of work around that. I hate workarounds. I think it's deception in some ways. But if you choose to work with two of these plans in particular, they will not pay for any hearing evaluation. And their argument is that because it's not a hearing evaluation, it's a hearing aid evaluation, and Medicare doesn't pay for that anyway. So you want to know what you're required to provide. How many rechecks do you have to provide, and what's the time frame in order to do that? So here are some hearing aid evaluation options that may be helpful for you if you choose to work with those plans. And even if you don't, work with the plans that make you give away hearing testing for free. The testing, especially S0618, is great. And this would be used mostly for internal purposes. So just some thoughts. You don't have to enroll in any third-party payer except for Medicare Part B unless you give all your services away for free, and I'm talking diagnostics. You really need to weigh the pros and cons of contracting, and there are many. For ADA members, you've got a most amazing resource in Dr. Kim Cavett, who can walk you through that. If you were an Audigy member, I can certainly do that for Audigy members as well. You don't want to make decisions out of fear. You want to make everything based on data and what you know. And again, if you're out of network, you can offer the patient the courtesy of billing after they pay you for services. So if you see didn't get paid as to what you were supposed to, it's becoming a chronic issue, you got denied for something that should have been paid for, you want to monitor that, look again at your contract, and you can appeal it and say, no, you made a mistake. And oftentimes that's very successful. But again, at some point, and these are the things you need to include, which I kind of already covered, the reason and the patient information. So finally, let's wrap it up with just talking very briefly about some of the other plans that you may encounter as a provider. Workers' compensation, and that's strictly for those who are injured on the job, and it's administered by both federal and state agencies, and it also may include lifetime coverage for services. So if somebody has an acoustic trauma on the job, they may get hearing aids for life, for example. So you may be seeing that patient for a very long time. There's also vocational rehabilitation, and their thrust is to help those with disabilities to access options mostly for employment. This is federally and state funded as well. Generally, there's a counselor you'll work with who seeks services for whatever that beneficiary needs, and that can include audiology services. And in many states, they require a bid process for hearing aids, so that you would submit a bid, and whatever bid they choose, it's not always the lowest one, is the one that they go with. And they look at a variety of factors too. And then finally, there's the VA, which is administered by the Department of Veterans Affairs. It's usually, if you go to a VA hospital, it's usually for those that are active duty, but not always. There are off-site clinics for retirees and others who qualify. So they may have an audiologist on staff at the VA at a center or hospital, and then they may outsource other services, especially you might remember after a lot of the vets came back from Iraq and Afghanistan, there was a lot of traumatic brain injuries, a lot of traumatic perforations. The VA was so backlogged that they started allowing private practice audiologists to do those kinds of visits, and then compensation and pension visits. So I think when you talk about insurance, I'll just let you read that. It certainly does make us older before our time. So I want to thank you. I'm happy to take any questions. I think we're just about a little over 9 o'clock, but I'm happy to take any questions. And thanks for attending not only this session, but all the sessions that SADA's provided for you, because these are incredibly well put together webinars, and I'm going to attend a few myself. So with that, Andrew, I'll hand it back over to you, or Anne Marie.
Thank you, Dr. Abel. We really appreciate it. Looks like we have one question in the queue that we will take real quick. Will these slides be distributed to students? So we are actually recording this presentation. It will be available. If Dr. Abel is okay with it, I'm happy to share the slides. Dr. Abel?
I am a-okay with it.
Awesome. So we will distribute that probably tomorrow morning to all of the registered attendees for this webinar. Sorry, go ahead.
Oh, no, I was just going to say, and there's my email. So if you have a follow-up question, don't hesitate to get in touch with me. I'm happy to try and answer it for you.
Awesome.
Thanks,
Thank you,
Andrew.
Doctor. Yeah. Do you have any additional recommendations for other resources that students might be able to check out in relations to this particular issue?
Wow, that's a good question. Dr. Cabot with it is, contracted with ADA. She's the best. She would be great. Dr. Spoor, I think, is your speaker next week. She has a lot of information as well. Any of the professional organizations I'll speak to those who are members of ASHA. They have an incredible staff, a big staff that deals with nothing but reimbursement and third-party payers and that type of thing. Dr. Cabot does that for ADA, and AAA also has staff and a committee that works with that. So you can look at all of their websites. There's different information on each one, and they all have their different strengths. And seek out resources of, colleagues, your mentors and folks like that.
Absolutely. Thank you, Dr. Abel.
Sure.
And thank you to everyone. Looks like we are out of time for today's session. If you have additional questions, please email them to me at info@audiologist.org, and we will forward those questions on to Dr. Abel. If you have friends and colleagues that were unable to attend the webinar today, please let them know that the session has been recorded, and we will send out the link to attendees after the recording is posted. For more information about future SATA practice management webinars and to register, please visit www.audiologist.org/students. Thank you and have a great evening.